An abdominal aortic aneurysm occurs when the abdominal aorta expands to a diameter that is 1.5 times the normal aorta diameter or larger. As the abdominal aortic aneurysm expands, it can press on the spine or abdominal structures, causing back pain or abdominal pain. But most abdominal aortic aneurysms do not cause symptoms and are frequently discovered on imaging tests that were ordered for a different problem. Approximately 2.7 million people in the United States are estimated to have an abdominal aortic aneurysm, but only half have been diagnosed because abdominal aortic aneurysms are often asymptomatic. Abdominal aortic aneurysms are a potentially life-threatening condition, since over 85% of aneurysm ruptures lead to death. Because aneurysm rupture is so lethal, abdominal aortic aneurysms are carefully monitored so they can be treated before rupture occurs. As with other arteries, the aortic arterial wall consists of 3 layers of tissue: the intima, media, and adventitia. Abdominal aortic aneurysms form when the middle layer, the media, is weakened. The medial layer contains smooth muscle cells, which produce the building blocks for the elastic membranes and collagen that hold the artery wall together. Having a strong aorta wall is important because the aorta is essentially a big pipe that carries blood flowing under high pressure. When the elastic membranes are depleted, collagen has more difficulty maintaining normal aortic wall strength and shape. The weakened aorta wall then starts to bulge outward, resulting in an aneurysm. Aneurysms can occur in the abdominal aorta and the thoracic aorta, as well as many other types of arteries. In this video, we will be focusing on abdominal aortic aneurysms. Most abdominal aortic aneurysms do not cause symptoms, but some do. The most common symptom of an unruptured abdominal aortic aneurysm is pain in the back, abdomen, or flank. The physical exam is usually normal, but 3/4 of patients with an abdominal aortic aneurysm larger than 5 cm in diameter will have a pulsatile abdominal mass. If an abdominal aortic aneurysm is suspected, an ultrasound should be obtained as the initial test. Patients who are diagnosed with an abdominal aortic aneurysm should be monitored with serial testing. Aneurysms with a diameter 5.4 cm or less may be followed with ultrasound. Aneurysms 5.5 cm or larger will need to be repaired and should be further evaluated with an abdominal CT scan with contrast. Smoking is the strongest risk factor for developing an abdominal aortic aneurysm, increasing the risk by 3 to 12-fold. Other risk factors include older age, male gender, high blood pressure, hyperlipidemia, central obesity, coronary artery disease, and family history of aneurysm with rupture. Inherited and genetic conditions such as Marfan syndrome and Ehlers-Danlos syndrome are also associated with increased risk. Several factors also increase the risk of aneurysm growth and rupture. Once again, active smoking plays a significant role, increasing the rate of aneurysm expansion by 20% and doubling the risk of rupture. Aneurysm size can also be a risk factor. The larger the aneurysm, the more rapidly it grows, and the more likely it is to rupture. As a result, larger aneurysms require more frequent monitoring than smaller aneurysms. Indications for repairing an abdominal aortic aneurysm include diameter 5.5 cm or greater, increase in diameter by more than 0.5 centimeters over 6 months, or onset of symptoms related to the aneurysm and not explained by another cause. Abdominal aortic aneurysms may be repaired by open surgery or by placing an endograft in the aorta during an endovascular procedure. The endovascular method is known as Endovascular Aneurysm Repair, or EVAR. Over the last 15 years, EVAR has become the treatment of choice for most abdominal aortic aneurysms and is used in more than 70% of cases. EVAR is less invasive than open surgery and has lower perioperative morbidity and mortality. Long-term outcomes are similar for both techniques, although EVAR may require more frequent re-intervention than open surgery. The anatomy of the aneurysm neck is the primary factor that determines whether EVAR is the appropriate treatment. Aneurysms with a minimum neck length of 15 mm, angulated no greater than 60 degrees, and cylindrical neck that is not irregularly shaped are the most suitable for endovascular repair. Aneurysms with a neck that lacks one of the ideal features may still be treated successfully with EVAR, but the more issues there are with neck anatomy, the lower the likelihood of treatment success. Once the decision is made to pursue EVAR, preoperative sizing must be performed in order to select the most appropriate endograft. Precise sizing is the key to avoiding graft failure after EVAR. To maximise the chances of obtaining an adequate seal between the graft and the aorta wall, endografts are typically oversized by 20% of the normal aorta diameter. Care must be taken to avoid oversizing too much. Oversizing beyond 20% increases the risk of device migration and the late complications of aortic neck dilation and aneurysm expansion. If the graft is undersized, there may not be proper endograft apposition to the aorta wall, which significantly increases the risk of type 1 endoleak. Type 1 endoleak occurs when an inadequate seal between the endograft and aorta wall allows persistent blood flow from the aorta into the aneurysm sac. In order to obtain size dimensions of the aneurysm, a CT angiogram, or CTA, is performed with a three-dimensional imaging reconstructions. Intravenous contrast should be given unless the patient has a contraindication, such as significant renal insufficiency. When CTA with contrast cannot be performed, a non-contrast CTA is often sufficient, but cannot provide details on presence of thrombus, patency of aortic branches, or occlusive disease in the iliac arteries. Accurate endograft sizing is only the first step to ensuring treatment success. The endograft must be properly oriented and deployed, which requires accurate imaging of the patient's anatomy during the procedure. Intraoperative imaging is most commonly done with fluoroscopy. The disadvantage to this approach is that some procedures can take several hours, which increases the amount of radiation exposure and contrast used. Intravascular ultrasound, also known as IVUS, is better suited to meeting the need for real-time imaging. Measurements obtained with IVUS are accurate to within 0.05 millimeters. IVUS is more accurate than conventional angiography for calculating the cross-sectional area of elliptical lumens. In addition, IVUS provides more accurate measurements of aorta length, which is often under or overestimated on CTA. IVUS is particularly helpful if the preoperative CTA was performed more than 3 months ago, since the aneurysm diameter may have changed during that time. IVUS is also essential for obtaining accurate measurements if the preoperative CT scan was performed without contrast or with large axial cuts 5 to 10 millimeters thick. As a second set of measurements, IVUS provides another layer of information that allows the physician to confirm the aorta and aneurysm measurements that were obtained on preoperative CT. IVUS can also visualize vessel wall morphology, such as calcifications and thrombus in the artery wall. It is vital to have an accurate picture of the vessel wall morphology in the aneurysm neck, also known as the proximal seal zone, which is the single most important factor that may limit treatment success. Assessing the calcium in the vessel wall can also help determine if balloon angioplasty is necessary before deploying the endograft. Another important advantage of IVUS is that it reduces the amount of time spent in fluoroscopy, decreasing radiation exposure for the patient, staff, and physician. Using IVUS also reduces the number of angiograms during the procedure, which is limited to brief runs to visualize the renal arteries and final graft deployment. Fewer angiograms mean that less contrast is used, which may decrease the risk for contrast-induced nephropathy, particularly in patients with renal insufficiency. Using IVUS during EVAR, however, does have limitations. IVUS cannot be used to assess neck angulation and may not be able to identify very small or stenotic branches. Aneurysms with an extremely angulated neck may also cause the IVUS catheter to sit at a suboptimal angle, resulting in inaccurate measurements if this is not recognized by the user. IVUS cannot detect an endoleak in the conventional sense because the sound wave is reflected by the graft material because it is highly echogenic. IVUS is unable to provide information about blood flow between the graft and the artery wall. IVUS can be used to identify a graft disconnect or infolding of a graft, which may be the cause of an endoleak. A completion angiogram should be performed after the graft is deployed to evaluate for endoleak. Pre-procedure instructions. Patients taking an anticoagulant agent must stop the medication prior to the procedure. Patients taking antiplatelet agents may continue the medication unless spinal anesthesia is planned for the procedure. Room setup and team roles. The procedure room should contain a fluoroscopy table, portable or wall-mounted C-arm fluoroscope, fluoroscopy monitors, and power injection system that will enable digital subtraction angiography. Patient monitoring equipment is necessary to assess vital signs during the procedure. A ventilator is required for patients receiving general anesthesia. Finally, the IVUS tower and monitor will be needed for IVUS imaging. Whenever possible, the IVUS tower and the C-arm should be situated on side of the table opposite from where the physician will stand. The monitoring equipment should be placed at the top of the table near the patient's head. The patient will lie supine, and the physician will stand on the right side of the patient and the table. A 3-member team during EVAR is ideal. The physician, a nurse, and a radiology technician who can assist in running the IVUS. Oftentimes, having another physician or physician assistant as first assist is helpful. When general anesthesia is used, an anesthesiologist or nurse anaesthetist should be present to manage the ventilator. The physician will scrub in and obtain arterial access, perform diagnostic angiograms, evaluate the aortic aneurysm with IVUS, and treat the aneurysm with an endograft. The nurse will administer heparin and monitor the patient's vital signs and clinical status. If using conscious sedation, the nurse will administer the appropriate medications. The radiology technician will operate the C-arm, obtain supplies as needed, and help with IVUS playback and image capture. Additional radiology technicians may assist with the procedure or scrub in to help manage the wire or wires. Setup and supplies. Prior to starting the procedure, the following materials should be prepared on a sterile table. Micropuncture access kit, 0.018-inch platform, 5 French to 24 French sheaths, 5 French pigtail catheter, Visions PV 0.035-inch digital IVUS catheter, 0.035-inch entry guide wire, 0.035-inch soft-angled hydrophilic glide wire, 260 cm long, 0.035-inch hydrophilic coated catheter, 260 cm long, 0.035 Lunderquist stiff wire or Amplatz super stiff wire. The following items should also be readily available: ultrasound machine for guided percutaneous access, non-ionic iodine-based contrast media, high-pressure tubing for power injections, per-close ProGlide devices or 10 French ProStar devices, endograft with contralateral limb, compliant moulding balloons such as Cook Coda or Medtronic Reliant balloon. The following medications should be available: 1% lidocaine, unfractionated heparin, IV formulation. If using conscious sedation, midazolam IV formulation, fentanyl IV formulation. Access. The most common site for obtaining arterial access is the femoral artery. Most abdominal aortic aneurysm endografts are bifurcated. The graft extends into the iliac arteries and require both femoral arteries to be accessed for the procedure. In this video, we will discuss how to obtain percutaneous femoral artery access. Percutaneous access may be used in femoral arteries that have adequate lumen size, usually 5 mm or greater, to accommodate and introduce a sheath or bare device. If lumen size is inadequate, a surgical conduit or endoconduit may need to be placed instead. Another method to access the femoral artery is via open cut-down, in which an infrainguinal incision is made, followed by dissection down to the artery and arterial puncture. Percutaneous access for EVAR can be obtained in over 90% of patients and is successful in more than 95% of cases. Advantages of the percutaneous approach include shorter procedure times, fewer wound complications, and less postoperative pain. The main disadvantage of percutaneous access is that a small number of cases may need to be urgently converted to open repair. To obtain percutaneous access, prep and drape the patient in the usual manner. Because EVAR cases require bilateral femoral access, prep both femoral sites as well. If not using general anesthesia, administer conscious sedation with intravenous midazolam and fentanyl. The box for the IVUS catheter may be placed by the patient's contralateral hip. This positioning may help avoid inadvertent contamination of the wire as well. First, identify the mid-femoral head on both sides. This is the ideal site for femoral artery access. Next, use ultrasound guidance to identify the optimal site of entry and insert the needle into the ipsilateral femoral artery. Ultrasound guidance helps avoid sites that are heavily calcified and ensures that the artery, not the vein, is accessed. In addition, using ultrasound lowers the risk of complications such as puncture site bleeding and pseudoaneurysm or arteriovenous fistula formation. Administer local anesthesia by injecting lidocaine under the skin and in the adventitia around the artery. Then obtain access with the 21-gauge introducer needle. Place the 0.018-inch guide wire with standard Seldinger technique. Next, perform an angiogram to confirm artery access. After femoral artery access is obtained, the per-close pro-glide devices should now be used to set up for access site closure at the end of the procedure. Exchange the 6 French sheath for the first pro-glide device and deploy the device with a 30-degree medial rotation. Continue to maintain wire access and deploy the second device with a 30-degree lateral rotation. Then exchange the device with a 6 French sheath. Repeat the pre-close process with the contralateral access site. Alternatively, the pre-close procedure may also be performed with a single 10 French ProStar device. At this point, someone unfamiliar with IVUS would normally advance an angled hydrophilic guide wire through the contralateral sheath beyond the renal arteries at L1 or higher. Then insert and advance the pigtail catheter until the tip is above L2. Remove the wire and connect the pigtail catheter with the power injector. Angiograms during the procedure will be performed using this catheter. In this case, we have elected to skip this step to minimize contrast, and we will rely on the IVUS to mark the relevant anatomy. Assessment, measurements, and decision-making. To proceed with treatment, insert an angled hydrophilic wire and advance it beyond the celiac artery into the descending thoracic aorta. Then exchange the wire for a Lunderquist extra stiff guide wire. Next, administer a bolus of IV heparin for a total of 5,000 to 10,000 units or 100 units per kilogram of body weight. The goal ACT should be approximately 300 seconds. Then prepare the Visions PV IVUS catheter. Flush the guide wire lumen through the Y connector port and activate the catheter's hydrophilic coating with heparinized normal saline. Remove the cap from the PIM connector and connect it to the patient interface module. Check the IVUS monitor to see if the device is imaging properly. Mount the IVUS catheter onto the guide wire and advance it beyond the celiac artery and into the descending thoracic aorta. The IVUS catheter should be advanced over a stiff wire because length measurements are obtained using the RadioPac IVUS catheter markings. Using a stiff wire with IVUS will result in more accurate measurements than using a floppy wire. Now start recording with IVUS in the descending thoracic aorta, pulling back slowly on the catheter. Note the location and appearance of the celiac artery, SMA superior mesenteric artery, site where the left renal vein crosses the aorta, renal arteries, aortic bifurcation, and common iliac artery bifurcation. With IVUS, heavy calcifications will appear bright white or hyperechoic, and will also present with acoustic shadowing or an area through which sound waves fail to propagate. It is particularly important to note which renal artery is positioned lowest, because that will determine where the endograft is deployed. Using IVUS to visualize the aorta and its branches can also reveal the orientation of the vessels, such as whether the renal vein is anterior or posterior to the aorta. Next, use the Visions PV IVUS imaging software to measure the aorta and aneurysm diameter. To measure the landing zones, the technician should freeze the frame and use the drawing tool to outline the lumen of the artery. The software will then calculate the major and minor axes if the lumen is elliptical, or the diameter if the lumen is circular. Begin by measuring the diameter of the normal infrarenal aorta. For aneurysms with shorter necks, measure the diameter in the seal zone proximal to the aneurysm every 5 mm for at least 15 mm. For aneurysms with longer necks, measure at sites of obvious diameter changes. Continue taking measurements at the aortic bifurcation and down through the common iliac arteries. Using IVUS to measure normal aorta and aneurysm diameters can help confirm the measurements obtained on the pre-operative CT. IVUS should also be used to confirm the length of aorta between the lowest renal artery and the aortic bifurcation, which will determine the length of the main body of the endograft. One method is to position the IVUS catheter just below the lowest renal artery. Then, pinch the catheter at the site where it exits the sheath, and under fluoroscopy, pull back until the catheter is at the level of the aortic bifurcation. Use the 1 cm markers on the IVUS catheter to measure the distance between the catheter where it exits the sheath to the pinched section of catheter. This will provide the aortic length measurement. Another method is to use IVUS to identify and mark the site of the aortic bifurcation, which is approximately mid-body L5. Then advance the IVUS catheter until it is just below the lowest renal artery, which is often mid-body L2. Under fluoroscopy, use the radiopac 1 cm markers on the IVUS catheter to measure the distance between the lowest renal artery and the aortic bifurcation. The same methods for measuring aneurysm diameter and endograft length can be used to measure iliac artery diameters and iliac artery length between the aortic bifurcation and the iliac bifurcation. Therapy. To proceed with aneurysm treatment, exchange the 6 French sheath for a larger sheath appropriately sized for the endograft or for the main body device if going bare. If using a floppy guide wire at this time, exchange it for a Lunderquist extra stiff wire. Check the ACT at this time. If the ACT is less than 300 seconds, give more heparin until the ACT is 300 seconds or greater. Some practitioners choose to utilize the IVUS catheter from the contralateral side to watch the deployment of the graft. This enables them to watch the graft unfold from inside the sheath and confirm the graft material is below the lowest renal artery while cutting down on contrast and fluoro usage. This can be especially helpful in a case where the patient has a high creatinine or is suffering from renal impairment, and minimization of contrast administration is of the utmost importance. Under fluoroscopy guidance, insert the endograft and rotate the graft while advancing to make sure it stays properly oriented. Begin slow, stepwise deployment of the proximal graft, starting about 1 cm above the target position. Pull down on the graft while deploying in order to position the top of the graft 0 to 2 mm below the caudal edge of the lowest renal artery. With the power injector, perform a brief contrast run using 12 cc of contrast or less to determine that the proximal endograft has been properly deployed. Make sure the renal arteries are visualized and that renal blood flow is preserved. The goal of placing the endograft as close as possible to the renal arteries is to create maximum overlap or seal within the aneurysm neck in order to prevent endoleak or graft migration. Once the proximal landing zone has been established, deploy the rest of the endograft, stopping at the contralateral gate. The next step is to cannulate the contralateral gate. More than 95% of cases can undergo contralateral gate cannulation using the retrograde approach. Insert an angled hydrophillic wire through the pigtail catheter in the contralateral femoral artery. Most practitioners will opt to swap the pigtail catheter out for a KMP or similar catheter unless the angle to cannulate requires a complex curve catheter, in which case a SOS, VS, Van Schie 5 or the like may be chosen. Leading with the catheter, point the tip in the apparent direction of the contralateral gate. Then slowly advance wire until it appears to enter the contralateral gate. This process may need to be repeated until gate cannulation is assumed successful. After assuming gate cannulation and advancing sufficient wire, remove the cannulation catheter and exchange for the IVUS catheter to visually confirm that the wire has cannulated the contralateral gate. Once proper positioning has been confirmed, exchange the floppy guide wire for a Lundequist extra stiff wire. Confirmation of gate cannulation is paramount as the docking limb will be placed over the contralateral wire and overlapped into the main body graft. The most commonly used method to determine correct wire placement is spinning the pigtail followed by the snowman technique or a graftogram. However, these techniques are often not definitive. Advancing the IVUS catheter is a surefire way to see the contralateral wire as it enters the contralateral limb, providing precise visualization of the location of the wire in relation to the contralateral limb. With the Lundequist wire in the contralateral gate, pull back on the IVUS catheter to align the IVUS markers with the flow divider marker to assist in measuring the length of the iliac artery. The iliac artery length will determine the length of the contralateral limb. Remove the IVUS catheter. Advance the contralateral limb over the Lundequist wire and deploy it within the iliac artery. Once the contralateral limb has been deployed, complete the endograft placement by deploying the ipsilateral limb. After the endograft is fully deployed, use a compliant moulding balloon to optimize the seal at the aortic neck, iliac gate and distal iliac limbs. Take care not to overinflate the balloon to minimize the risk of artery rupture. Confirmation of treatment. Advance the IVUS catheter over a wire to visualize the proximal portion of the graft. Examine the normal aorta superior to the stent, the celiac artery, superficial mesenteric artery, and renal arteries. IVUS can also be used to identify any graft infolding within the seal or overlap zones, as well as compromised outflow due to stenosis at the aortic bifurcation. If limb kinking or stenosis is identified at the aortic bifurcation, treat the narrowing with kissing balloons. If the balloons do not resolve the problem, a bare metal stent may need to be placed. Balloons may also be used to treat infolding, which can occur due to excessive graft oversizing. If ballooning is unsuccessful, an uncovered stent may be placed to hold open the lumen and ensure adequate distal runoff. After identifying and treating any complications, use the power injector to perform a completion aortogram. Confirm the patency of the aortic branches, especially the renal and hypogastric arteries. The post-treatment angiogram is also used to identify any signs of endoleak, which cannot be detected with IVUS alone. Closure. With the wire still in place, remove the sheath. While holding pressure with manual compression, use the knot pusher to cinch down the knots that were placed by the ProGlide devices at the beginning of the procedure. If pulsatile bleeding is present, a third ProGlide may be deployed over the existing wire. After achieving hemostasis, remove the wire and apply manual compression. Repeat the same process with the opposite side. After the patient arrives in the post-anesthesia care unit, the lower extremity peripheral pulses and neurologic status should be closely monitored. The patient should also be hydrated post-procedure, and renal function should be followed by monitoring creatinine levels. If the patient's antiplatelet medication was discontinued for the procedure, it may be restarted at the physician's discretion. Patients who require anticoagulant agents should resume their medication when the physician determines it's safe to do so. Patients may be discharged home on post-procedure day 1 if they are able to void, ambulate, and tolerate a diet. After discharge, patients should follow up with their physician and undergo a CT scan at 1 month. If an endoleak or other abnormality is seen, the next CT scan should be performed at 6 months. Otherwise, a repeat CT scan is not necessary for another 12 months. On the 12-month CT, if the aneurysm appears stable or begins to shrink, the patient may be followed with annual duplex imaging from that point on. Another CT scan is not required until 5 years post-procedure.